del IKDR. Bienvenido en Montreal de manera virtual. Este año el grupo se ha hecho internacional con países que se unieron a nosotros de Asia, de América Latina y de Europa. Tenemos un programa muy interesante de 90 minutos con una presentación dedicada a Dr. Kawasaki sobre el MIS-C y todo lo que tiene que ver con la pandemia. Les deseamos una buena sesión y webinario.
¿A moi?
Yeah, next slide.
Okay, well, welcome again. So we will start this session with two main points. If you have questions, there's a Q&A spot where you could drop these questions. And there is also the chat room. We prefer that questions being dropped in the Q&A box for this afternoon. I'll go over very quickly over the session of this afternoon. When I say afternoon, it's Montreal time. So please mind the difference for your time zones. So all microphones will be muted because we're on a Zoom webinar mode and not a open discussion. As I said, please select the Q&A once you have any questions when the question period is launched. And if you have any technical problems to drop in, please go to the chat room and ask this question and we'll address it. Please remember that this event is CME certification will be issued from the University of Montreal. So by the end of this session, of this 90-minute session, you will receive by email a request to fill in your assessment and evaluation. A program overview. So we start with a scientific session dedicated to Dr. Kawasaki's life and passing. It's going to be moderated by Dr. Audrey Dion and Dr. Matthew Elias. Audrey is a pediatric cardiologist from Boston Children's Hospital, and Matthew is from Children's Hospital of Philadelphia. Our keynote speaker today is Professor Robert Tullow from Bristol, UK. Following this session, we will discuss other research efforts, other ongoing research efforts. Will be moderated from Dr. Guillermo Goldenberg from Chile. The speakers will be Dr. Jane Newberger, Dr. Adrienne Randolph, Dr. Jane Burns, and Dr. Michael Portman. And we'll end with a wrap up at the end of the whole thing. So I have the pleasure to present our junior and very dynamic members of the IKDR. Audrey Dion from Boston Children's Hospital, who's a pediatric cardiologist and electrophysiologist, and Matthew Elias from CHOP, who is also a pediatric cardiologist with great interest in Kawasaki disease. The stage is yours.
Well, thank you very much. Hopefully you can hear me here. And it looks like others have the slides. So
Matthew, please unmute yourself.
Should be unmuted?
Yes, and okay. Please load your slides if you want to use your slides, otherwise we'll run them for you.
All right, thank you. Hopefully I'm through the technical difficulties. So thank you so much. My name is Matt Elias. I'm a pediatric cardiologist at the Children's Hospital of Philadelphia. I'll be co-moderating this session with Dr. Audrey Dion, pediatric cardiologist from Boston Children's Hospital. Before we pass over the floor to our keynote speaker, Professor Robert Tullow from the United Kingdom, University of Bristol, we want to say a few words about Dr. Kawasaki, who we lost a few months ago. Dr. Kawasaki was born in 1925 in Tokyo, and he worked here for many years as a staff pediatrician at the Japanese Red Cross Medical Center. The bottom of the screen is actually the entrance to the pediatric ward where he worked for quite some time. About 10, 11 years later, after starting there, he encountered his first case, who many of us have heard all about, a 4-year-old patient with a diagnosis that was unclear at the time. He described it as, "I never experienced such a complex case of clinical symptoms." and it was filed away as a diagnosis uncertain, or GOK, God only knows. The following year, he saw another patient and then 5 more patients, and he presented these findings at a local Japan Medical Society. Yet he remarked he was the only one who was interested. He was met with very firm opposition from the academic community, and his ideas were essentially rejected. However, in 1967, he published his landmark article of 50 cases of the disease that soon thereafter would bear his name. And here he is in 2006, receiving the first Japanese Pediatric Society Award and showing on a big screen to many people the information from that very first patient, the 4-year-old patient from 1961. When I asked others how they would describe Dr. Kawasaki, I heard incredible terms. He was dedicated, courageous, inspirational. He was a role model, yet he was humble and gracious, welcoming, engaging, warm, enthusiastic. And then he was the life of the party. He was described as the cheerleader in chief, really promoting science and the further development and advancement of the field. And more than one person described him as a rock star. Several people described him as a rock star. In fact, that's how the Chicago Sun-Times reported him as. They wrote an article in 2005, grateful parents treat doctor like a rock star, as he visited Chicago and was able to meet a family with Kawasaki disease, their young child with Kawasaki disease, and he remarked on how wonderful it is to see great outcomes. His passion did not lie only with medicine and Kawasaki disease. In an interview previously, he talked about growing up, he had a passion for fruit, and he was very interested in why the pear came into existence in the early 20th century. And here there's a picture with the animal, the okapi, an animal at the San Diego Zoo. And every time he would visit San Diego, the team there arranged for a behind-the-scenes tour of the okapi, which he found very fascinating. He was convinced that this animal was a final dead-end lineage with giraffes. And actually, a few years later, there was some genomic sequence testing that turns out the animal was, well, related to a giraffe, was actually a branch off of cows instead. But the team there didn't have the heart to tell him. But I think if history has taught us anything, and he has proven his doubters wrong. So I'm not a betting man, but if I were, my money would be with Dr. K. So thank you, Dr. Kawasaki, for being an incredible physician, an inspirational role model for everyone who wants to follow in your footsteps. And from talking with everyone here and gathering wonderful photos and stories, I can say thank you for being a wonderful person as well. So to honor Dr. Kawasaki, I'm very privileged to introduce Professor Robert Tullow. Let me stop sharing my screen here. Professor Robert Tullow is a consultant cardiologist at University Hospitals Bristol and the Bristol Heart Institute. He is professor of congenital cardiology at Bristol Medical School and the University of Bristol. He graduated in medicine from Oxford University, completed his training in pediatrics and pediatric cardiology, including training locations at Dartmouth Medical School, Johns Hopkins Hospital, and pursued his thesis at the British Heart Foundation as a research fellow at the Institute of Child Health in London on neonatal pulmonary hypertension. He's extremely involved in research to develop new methods of assessing and treating pulmonary hypertension in children and adults with congenital heart disease, of course, Kawasaki disease, and also viruses in general with congenital heart disease. He's been a key author in major trials on RSV prophylaxis, congenital heart disease. He's been the director of medical education. He's written 44 book chapters, has published more than 265 items, has given over 220 presentations at international meetings. And Dr. Tullow, thank you for joining us, and this might be 221.
Thank you very much. Thank you for introducing me. I'm not sure that I could claim to be a rock star, but I'm happy to be honored to give this talk in honor of Dr. Kawasaki. It's always difficult giving these talks to such erudite audiences who probably know far more than I do about the topic, but I'll do my best to share some of my experiences with you and keep you all interested for the next few minutes. My disclaimers are luckily very short. There's no conflict of interest. I make no apologies for this slide. I'm sure everybody in the audience knows all the features of Kawasaki, but I just wanted to point out a couple of things that certainly some of the junior colleagues or some of our colleagues who are not expert in Kawasaki, to remind them the differences between complete, incomplete, and atypical Kawasaki, that you don't need all the features present. And as you see in our talk in a few minutes' time, this is very, very important. Many children do not have all the features present, certainly at the time of diagnosis. And one of the things I like about this condition is that you have to be a good physician. You have to take a good history. And often the parents have got pictures on their phone of a rash that came and went 4 or 5 days ago, of some red eyes that were just there fleetingly. And it's not until the penny drops and that people actually make the diagnosis. It's one of the things that I've been working hard on with a variety of support groups, including society, who support this talk, in order to try to get the awareness raised in the UK, which is not always as easy as you think it might be. In the past, we thought that this slide was all correct. We thought that there was a male predominance, may or may not be a family history. From my point of view, I've seen very few run-in families with siblings or parents with Kawasaki disease, but it is known. We've seen the work on genetic susceptibility. We don't have many Asian or Pacific Islanders in the UK, but certainly African, Black African descent is important. Although 6 months to 5 years is typical, 25% of our patients are outside these age groups, and people often forget when they see a 15-year-old that he could possibly have Kawasaki disease, and those worst cases are those children who are under 6 months. We found just the opposite. It's not urbanization that leads to Kawasaki, and this might have some of the answers as to why there aren't seasonal peaks in the Southern Hemisphere, more of which I'll talk about in a minute. So we don't know the origin, but certainly the great work that Javier Rodon and Jane Burns have done in the past looking at climate are very important, and something that we'll be able to report on shortly in the medical literature. Certainly in England, the instance, the reported instance of admissions to hospital with a diagnosis of Kawasaki disease have been rising quite fast. This is a 4-fold increase over the 10 years to 2015, and we're soon to update this for the next 5 years, showing a 7-fold instance increase in admission to hospital with a diagnosis of Kawasaki disease over a 15-year period. So no more can we call this a rare disease, and I take great issue with people who call this a very rare, a rare condition. Certainly does not suggest that this is a rare condition, and I'm sure all of you here are on the same page as me, and I look forward to hearing more about this in the future. This talk is not about the acute management, but I did want to put in just a couple of features of interest. One is to talk about steroids. The issue about the use of steroids acutely is still unresolved, and we're about to start, we just have started our multi-center trial in Europe of using steroids as primary therapy for Kawasaki disease. And this will be hopefully a method of reducing the terrible incidence of coronary artery aneurysms. And then the long-term follow-up, the choice of how we manage these patients, the anticoagulation that we use is still up for discussion, and we'll talk about this more over the next few minutes. And all this is detailed in the main UK journal, which Despina and myself and some of the other interested Kawasaki-ologists in the UK have been writing. Last year, we published our British Paediatric Surveillance Unit study, which is from the whole of the UK and Republic of Ireland over a 2-year period. The good thing about this study is that it was a population-based study, that any pediatrician, GP, pediatric cardiologist, rheumatologist could report a case. And we reckoned that we had probably 60 to 70% of all cases reported in the UK. It wasn't just from cardiac centers. And this gave us a nice confirmation of the late winter, early spring incidence of Kawasaki disease. We had over 600 cases reported to this study. most with complete Kawasaki, but increasing numbers of those with atypical, i.e. just a few symptoms of coronary artery disease, or those with incomplete symptoms, so less than 4 out of the 5 features. And we had 3 deaths during the study. 2 were within the 2-year reported study. But it gave us a really nice population basis, which is something that the NHS can deliver. There are many things the NHS can't deliver, but this is one. And we've really enjoyed trying to get to the grips of what's happened to these patients. One of the interesting features was this, which we reported in 2016, soon after the study had finished, that most of those children who have only one symptom have cardiac disease. And that is a real surprise, i.e. typically they've had a fever and then they may have had a rash, and they may have no other symptoms at all. Now I say cardiac disease carefully, not coronary artery aneurysms. Some of these children had myocarditis, some had pericardial effusions or valve regurgitation, but 55% of those children with just one symptom and a fever had cardiac involvement, and most of that was coronary artery aneurysms. Whereas by the time you get to the classic symptoms and people have got mucositis, they've got cracked, red, dry lips, everybody makes a diagnosis. And so it's not surprising that we pick up many more milder cases. But it does show the huge range of percentage of children with just a few symptoms compared to those with many symptoms. Some of this to do with a late diagnosis, but it may also be a phenotype matching, and it's a very significant change, something that we try to teach our emergency medicine doctors, that they don't have to have all the features, which is why my first slide was in my talk. This is one of the other features which we notice exactly the opposite: urbanization. And this really flies in the face of those people who feel that they're looking for a virus or a group of viruses to label as the cause for Kawasaki disease. I didn't draw this figure. It's completely separate from me. Our statisticians drew it, and we're very excited, is in areas with very low population density. And you remember that there have been several studies that have shown proximity to bodies of water, proximities to be in the country, that suggest that this might be part of the etiology for Kawasaki. Is it to do with funguses? Is it to do with insecticides from farming lands? I don't know, but certainly if you remember the original study, people looking at the winds blowing off the steppes of Asia over Japan, leading to high incidence of Kawasaki disease. Is this related? We'll have to see. So roughly 39% of children under 1 year have coronary artery aneurysms, and certainly those with late presentation. Those with Black African or mixed ethnicity, and as you know, those with positive inflammatory bloods and who are male, and the other key features in the Kobayashi scoring. Although those have been not really closely adherent to the UK population, it is something that people still tend to point towards. And the treatment we have in the UK is the same as anywhere else in the world, with intravenous immunoglobulin and aspirin, and they go home on aspirin if they don't need other treatment. Certainly, echoes, as all the pediatric cardiologists are aware, but my colleagues keep thinking just it's coronary arteries, and myocarditis, pericardial effusion, and valve regurgitations, as we'll see in a minute, are also always important. We use Z scoring, just like in North America, unlike some of the countries further on the east. And it's very easy to see coronary arteries when they're a little bit big and they look like coronary arteries, but it's much harder when you have something that's left anterior descending. This one had a Z score of +17 compared to just a nice little bit of a dilatation at the junction of the LAD and the circumflex, which would be typical for Kawasaki. Or in this child with a dilated right coronary artery, and many a time this will be missed by cardiologists not expecting to see a coronary artery looking like this. This chap had a Z score of +26, which is pretty big for a 4-month-old. So this is his angiography showing a very large right coronary aneurysm, fairly standard work. Late presentation, he turned up at 15 days into the illness. Everybody said, oh, Kawasaki is too rare. It can't be Kawasaki disease. hopefully I've been trying to train people up, and he's done really well with giant coronary artery aneurysms and has had no complications. Not everybody is so lucky. And we really got alerted to this after 2 children in London who were known to have Kawasaki, known to have coronary artery aneurysms. A plan was in place for their care, but still when they presented with chest pain, they weren't managed appropriately. They were sitting in beds waiting for images taken the next day to see if there's any thrombus or any stenosis, and they came to serious harm. So every doctor in the UK got alerted to the risk of acute coronary syndromes in Kawasaki disease. And that's really what we're mainly talking about during this evening. This led to a consensus paper, which was published just a few weeks ago, mostly made up of adult cardiologists, but also 2 or 3 of us pediatric cardiologists, rheumatologists, general pediatricians, politicians, parent support group, and it was endorsed by the College of Pediatrics, British Cardiovascular Society, Emergency Medicine, general practitioners. Everybody across the UK said this seemed like a good idea. The paper is obviously fairly detailed, and this is just a quick summary, really to show the similarities and differences with the Circulation AHA paper published in 2017. So those children who've got the classification in groups 1 or 2, i.e. no involvement or just a bit of dilatation, settles down within 6 weeks, Z-score never went bigger than 2.5. We discharged those children in the first year with advice from the GP, perhaps to check their blood pressure, give them good healthy advice, avoid obesity, diabetes, etc., as you'd expect. So really the management on long going is those children with aneurysms, whether they're small or medium, whether they persist or resolve, and of course, especially those with the giant coronary aneurysms. And these are the groups that really cause us most anxiety and which I'll see in my long-term follow-up clinics. They all get aspirin lifelong, even if they had an aneurysm which completely resolved, and those with the giant coronary aneurysms will have warfarin or heparin if they're infants. Some of the larger medium aneurysms will give aspirin and clopidogrel. And then most of the discussion is around this area in terms of should we do MRI, should we do stress MRI, should we do exercise stress, CT? It's not yet worked out, and I want to show you what we've been doing. We give every patient a person-specific protocol, and this is useful for the patient and for the NHS, for the ambulance service, that should the patient, be they child or adult, turn up with acute coronary symptoms, chest pain, sweating, feeling really unwell with known Kawasaki disease and any history of aneurysms, then all the information is available on this, and the copies are available of this protocol in the actual journal. So I won't go through the whole pages, but the useful thing about it is that it tells the ambulance service what to do. Each patient and each local doctor will get this agreed with their ambulance service and the local cardiac center, so that it becomes clear that they should be taken straight to a pediatric cardiac surgical center, and the patient will have the key doctors' phone numbers, their names, a copy of their ECG either attached to this or as a digital copy, which they will present with the patient when they actually go to the emergency room. And of course, if we can give them the imaging, either printout or digital imaging, this really helps the comparison for any acute event. So the acute events, well, Kawasaki disease shock syndrome is another whole talk, and I'm really not going to go into this. And no talk is complete without mentioning COVID or pediatric inflammatory multi-organ syndrome, as we call it in the UK, or multi-organ inflammatory syndrome in children. So I'm not really going to discuss that. That I think we're going to be talking about in a bit. But we do see children who have valvulitis, and I remember this little girl, 18-month-old, who turned up with unrecognized Kawasaki disease. Retrospective history, it seemed to have been about 3 but she really presented in acute heart failure because of severe mitral regurgitation. She had torrential regurgitation, and within 2 hours of arriving at our hospital, she was shown to have a ruptured anterior mitral valve leaflet perimuscle and had mitral valve replacement. She was supported on ECMO for a few days, but actually did extremely well and is still in good condition now 5 years on from really quite a nasty presentation. So just to remind people, don't forget the valves and the function as well as the coronaries. It's not just about the coronaries. Coronary artery rupture is of course very rare. I've only ever seen one case, and this child presented with an acute tamponade in shock to the ITU, went to the emergency room where they saw the rupture. Unfortunately, the child didn't survive. There are only a few recorded cases in the literature, and they tend to occur either very early on with a severe inflammatory process going on, or even 20 years on with calcification and stenosis around the site of a very dilated aneurysm. So it's something that's, if you're lucky to pick it up and manage it, then it's really uncommon. More often do we see those who've had coronary artery aneurysms. So overall, we had 19% of the UK and Ireland patients have coronary artery aneurysm despite satisfactory treatment early on. And I said earlier, 39% of those under 1 year have coronary aneurysms. So this is a really major health hazard. So we've got tens of thousands of children and adults in the UK who are growing up with the sequelae of coronary aneurysms. And we know from the Japanese data that 50% of those with giant aneurysms will have MACE or major adverse coronary events, either ST elevation, myocardial infarction, need transplantation. I know 2 children have had cardiac transplantation because of Kawasaki, or they've died, or they've had to have urgent intervention, surgical or emergency catheterization. So in the paper, we put out this as a guide, and I apologize. Actually, I don't really. This is sort of a detail of what we advise patients to do and clinicians to do should a child present who's got known aneurysm history, but they've got evidence of myocardial ischemia. Ideally, they've got this person-specific or patient-specific protocol in place, and they can go directly through to the emergency cardiac center. Now, in the UK, we have 3 types of pediatric cardiac possible arrivals. This could be the cardiac surgical center. These are that we have 10 of these in the UK, which do all singing and dancing pediatric cardiac surgery. We do have pediatric cardiac centers. So these will be places where there are cardiologists. They will do acute intensive care, but they will not do interventional catheterization, or they won't do cardiac surgery. And then we've got secondary care, just a pediatric emergency department where they'll be able to manage and receive children who are acutely unwell, but they may not have any cardiology or imaging on site. So if a child turns up at the emergency department and they can get transferred to the cardiac center within 90 minutes, we say, fine, just send them as quick as you can, we'll manage the rest of it. They should have a dose of aspirin if the parents aren't aware or haven't given the aspirin or forgotten to give it, if the child was known to have an aneurysm and we think there's a coronary event. If, however, it's going to be more than 90 minutes to get, and some of our centers, just like in Canada or the US, are a long way from a cardiac surgical center, needing fixed wing transfer, you can't do this routinely within 90 minutes. So we would advise starting thrombolysis, and administering TPA is not something that cardiac or general pediatric centers will feel confident at doing. So attached to the article was a full pharmacopoeia, giving people the doses, giving them confidence, and saying, call us, the cardiac surgical centers, if you're not sure. Bear in mind, the troponin and ECG may be normal, even if there's acute coronary occlusion in Kawasaki patients. Troponins are one of my bugbears. More often than not, I get rung from the emergency department saying this child is a teenager, no cardiac history, nothing defined, we came in with chest pain, and somebody did troponins and they tell me it's elevated. What am I going to do about it? And so all the pediatric cardiologists here will absolutely share my opinion that I tend to say to them, you did the test, you sort it out. I'm not interested. Obviously completely different if the child's got a cardiac history, but troponins generally are not my favorite test in the general patient with chest pain. Some will have a normal ECG, in which case, of course, you need to think about imaging and see, compare with their previous pictures, is there evidence of a change? And similarly, some children will have NSTEMIs, and they may need some heparin starting, get some imaging, think, is a thrombus going on, before discussing with us and transferring, which they often do, but maybe less of an emergency, not in the middle of the night. So this is a useful first half of the diagram, and this is the second half. So ideally, the patient will then arrive very promptly at the Pediatric Cardiac Surgical Center. We'll do a variety of investigations, and if they have STEMI, they don't go to the ward, they don't get an MRI, they go straight to the cath lab. And every pediatric cardiac surgical center has got adult interventional cardiology right next door. And that's been one of the major advances to the networks that we've set up in the UK over the last 10 years. So I'm not familiar with stenting coronary arteries or ballooning some 2mm coronary vessels, but my adult colleagues do this all the time and are very, very competent and very confident at it. If we find thrombolysis, that's easy. We can give local TPA because we're actually right there next to the clot, the thrombus that's there. And if there's stenosis, they can go ahead and balloon them. We are really not keen on surgical intervention. This is only done if there's failure of intervention, the cardiologists aren't confident, and generally, if there has to be a graft, then really arterial grafts are patent. But you've only got a reamer and a lemur, you haven't got any more vessels to go, and so we're really unkeen. And if somebody's got forward flow through their stenosis and you give them a graft, it's likely that one or both of these will block. So we're much more keen on catheter intervention. Thrombolysis is everything in these patients. Many times stenosis, it might be there, but it's not usually causing an acute problem. And then there are a whole lot of drugs for post-intervention. Again, our adult cardiologists use this all the time, abciximab, eptifibatide. These are all standard to them and something that we will end up discussing with them. But again, all the drugs are here for people who may not be so familiar with using them. So for example, we had this lovely 4-month-old girl who turned up, parents were on holiday. I live in a nice part of the UK, so people keep coming here for holidays, which is why I'm in my cottage at the moment. This child had a giant coronary aneurysm, was perfectly well. Because of the infants, we find warfarin is difficult to get nice levels, so we tend to use subcutaneous heparin and aspirin. But she presented 6 months later, and the echo suggested there was some thrombus in the giant coronary aneurysm. So we took her to the cath lab, and this is the angiogram, and you can see that the upper left corner of this LAD has got significant coronary thrombus. So she was given systemic TPA. We took the line out, we made sure it healed up nicely, pressure dressing, and got the surgeons to sew up the hole in the artery, and then we can give a proper systemic TPA. We felt that was safer rather than leaving a catheter in the coronary artery of a child who's just 10 months old. And one of the things that we found that we have been increasing our anti-10A range, and this was something that Jane Burns has been helpful with us as well. They found similar problems, that the usual therapeutic range is not sufficient. So we've been tending to get them up to around 1, and this has been quite effective at preventing thrombus in young children who are on the heparin and aspirin and not on the warfarin. Past about 1, I tend to convert them to the warfarin, and it's parental choices. Obviously, it's difficult if they're still being breastfed, but once they're past that, then getting them onto warfarin is generally a more stable situation. Here's some pictures, which I'm sure you know well from the HA document, which I find really helpful when lecturing to adult cardiologists who may not be familiar. They're thinking of atheroma all the time, but describing the myofibroblastic proliferation that we see in Kawasaki, and the stenosis that occur at each end of the thrombus, and the calcification that occurs within the wall. And calcification is a very good clue to us to whether somebody has had chronic inflammation. And the nice paper by John Gordon has sort of shown their experience, and we found this useful in our experience too. In order to try to manage these children and adults with the sequelae of giant coronary aneurysms. Here, for example, in slide B, you can see the calcification in the wall of this very thick coronary artery, the narrow lumen. It's not surprising these people run into problems, and explains why rotational atherectomy might need to be performed in patients who've got significant occlusion in the longer term. Different sort of child now, young adult. She came to my attention when she was 18. She was known to have a giant aneurysm, previous Kawasaki, followed up in Manchester. But she was extremely fit. She was a county swimmer. She would do 2 hours of swimming training each morning, but then she presented with chest pain. And so they were going to do a bypass graft on her. And I said, hang on a minute, don't do it. Let's have a look at her. So we had a look at her. These are her pictures. A lovely giant aneurysm in the right coronary with 3 millimeter thick calcium. And clearly this was thought to be the problem. She had a smaller proximal LAD stenosis, but that wasn't thought to be too much of a worry until we did her FFRCT. And as far as I know, there's information, this is not yet standardized, but you can see that the right coronary is given a big aneurysm, but the problem actually is just here at the origin of her LAD, just after it's given the circumflex branch, with a significant reduction in flow. But she was quite well. What should we do about it? So what we did MRI perfusion with adenosine stress, which is now our standard protocol. She didn't have any gadolinium late enhancement, so there's no evidence of fibrosis, but she did have an inducible perfusion defect in these various areas. What should we do? She was very unkeen on us doing anything. She had the pain had all gone. She was fine. She was off to Thailand for a year, left her alone. So as far as I know, she's about to come back from Thailand, where they've had very little COVID, and we'll have to carry on deciding what to do. But in general, the older child, a young adult, the youth with stenosis and no ongoing problems, we generally leave it alone and we try not to intervene. This is the adult part of the protocol, which we've got plasticized and stuck up in an adult emergency department, very similar to the pediatric one. But a good thing about the adult patients, they all go to a heart attack center. Therefore, it's very easy for them to go straight to the cath lab, and adult cardiologists are set up with this every day of the week, and they're much more familiar than we are. They're less familiar with thrombolysis, but they're very good at the interventions. And so we found this is quite a helpful guide to them to saying what we would expect. Again, the ECG troponins might be normal, so reassuring them that if they think there's something going on, take them to the cath lab and have a look. They may need to do OCT, optical coherence tomography, or intravenous intravascular ultrasound. That may help them decide as to what to do next. But of course, the aneurysms are gone, the patients can be discharged, there's no worry. And certainly I'd never previously heard that a regressed aneurysm, small aneurysm, was thought to be a problem. There has been evidence from the Japanese for years that the endothelium is abnormal in people whose aneurysms have resolved. There have been numbers of papers that have shown that the endothelium doesn't behave normally. And we showed in 2014 that children 20 years afterwards had abnormal circulating endothelial cells, even if their coronary arteries were back to normal. They had no aneurysms now, or they had regressed aneurysms. They clearly were behaving much more like those who still had aneurysms than those who were quite normal. So this gave us a bit of a clue. So when this 19-year-old medical student turned up, known to have had Kawasaki disease, just a small aneurysm, he represented with chest pain, and we thought, oh, he's just anxious. He's a medical student, can't be too much to go on. Did a stress test, ECG on him, and he had some ischemia. We did his CT scan, and this showed some flecks of calcium in the coronaries that weren't that normal. Again, he's now undergoing it. It does show for the first time to me that those who have resolved aneurysms can have calcium in the wall, can have risk. He's not had an intervention. He's not had any adverse events yet, but it does cause me significant worries to all those children who have been discharged in the past. In the UK, we've looked at a large number of patients in the adult clinics who are less than 50 years old, undergoing coronary angiography from the Bristol Heart Institute. We found that just under 5% of them had coronary aneurysms and may well have had Kawasaki disease in the past. So we then went on to a study which just been accepted in the literature to try to understand how we can assess these adult coronary angiograms better. The pediatrics were familiar with Z scores, were familiar with echocardiography. Of course, that isn't much used for the adults, and they don't have Z scores for the adults, and they're forever seeing aneurysms, but usually post-stenotic dilatation. So we tried to understand, could we quantify and evaluate the 3D characteristics from angiograms and actually say whether they were abnormal or normal. So we derived a whole set of normal data that's now been accepted as a protocol. So we're going to try this out on a variety of adult angiograms and say, can we divide those into coronary artery aneurysms secondary to Kawasaki and normal? And this could be a useful screening test for those relatively small numbers of adult patients, but of course going to be increasing numbers, less than 5% at the moment, but who knows what it's going to be like in the future. There are many unresolved questions. I'm looking forward to the IKDR with my colleagues here, sharing some of the answers in the future. What about the patient who's completely well? They've got asymptomatic giant coronary aneurysms. What should we do for them? How do we assess them? Angiograms with turbulent flow and an aneurysm, not so easy. FFRCT is not validated. How should we follow up those children and young adults who've got resolved coronary aneurysms? I'm much more anxious now after that last case. Is there anything we can do to stop that stenosis? We can intervene. Sirolimus, should we use some of these drugs that the adults have been using for years? Is that appropriate for myofibroblastic proliferation? And what about the role of statins, their anti-inflammatory response? I'm using more and more of them because I think they have general benefit, but who knows in the Kawasaki patient? Thank you very much.
Thank you, Dr. Tzulak. That was a wonderful presentation. I think as people have alluded to this morning, coronary events are relatively rare after Kawasaki, but they have significant morbidity and mortality, which highlights the importance of being ready to manage these patients. We had a few questions to ask the audience to better understand what's being done around the world and help start the discussion. We'll try to move through them relatively quickly due to time. So can we get the first question up?
Read out the question, please.
Oh, we had the poll questions we wanted to go through first. Okay, so the question number one is, have you or your institution encountered a patient with Kawasaki disease experiencing an acute myocardial infarction? So you can click yes or no, and then we will show the answer in just a second. Okay, so can we display the answers? So it seems about half of the people have encountered patient and the other half did not. And I'm sorry, I think we've just noticed a technical issue where the panelists are not able to vote. So let's move on to the next question. Can we get question number 2? Okay, does your institution currently use a person-specific protocol for patients with Kawasaki in the event of an acute cardiac event? So again, yes or no. Okay, can we display the answers? So it seems like only a minority of centers use patient-specific protocol. And just to follow up on that, can we get the next question? So after this presentation, are you planning to implement person-specific protocol for patients with Kawasaki disease and coronary aneurysm? Can we get the answers now? So I think you made your point through the presentation. with Adult Center and being able to have some of our adult colleagues come over and help us in those complex cases.
Aspects of what is going on. And I would like to present our next moderator, Guillermo Larios Goldenberg from Pontificia Universidad Católica de Chile, who is a new junior member to the IKDR, who is also an active member in associating collaboration across Central and South America. Guillermo, I'll let you introduce our speakers. The stage is yours.
Thank you so much, and thank you for the opportunity to moderate this session. So it's my honor to introduce these outstanding speakers who will present the new research efforts ongoing in MIS-C and Kawasaki disease also. We will have 4 keynotes, and at the end of them, we will have a little less than 10 minutes for questions. So please use the Q&A, and I will be happy to read them at the end. Our first presenter, our first speaker is Dr. Jane Newberger. So please, if Dr. Newberger, you can share your screen. She's the Associate Cardiologist in Chief of Academic Affairs and the Director of the Kawasaki program at the Boston Children's Hospital. And today she will be discussing with us the music study.
Thank you very much. Yeah, thank you very much, Guillermo. So the aims of the music study are to characterize the occurrence and time course of coronary artery dilation and coronary aneurysms in MIS-C associated with COVID-19. To do the same for the occurrence and time course of LV dysfunction, to characterize the occurrence and course over time of systemic, meaning non-cardiac organ dysfunction, inflammation, and major medical events, including death, and then to develop clinical risk stratification models for higher coronary maximum Z-scores or worse LV systolic function and an evolution over time. This is an observational cohort study. There is research funding available for echoes and cardiac MRs that are not ordered by the primary provider. There is follow-up with annual medical history forms for up to 5 years. In contradistinction to some other studies, there will be an echo and MRI core lab, also a biorepository for optional DNA studies. The study will have a waiver of consent after 3 unsuccessful attempts to locate a patient or family, or for patients that die before consent. Patients in this study can be enrolled at any time in the first year after MIS-C onset. Prospective cases can be enrolled as early as hospitalization, and for retrospective cases or in those in whom consent couldn't be obtained during hospitalization, we'll send a letter and an opt-out card in English or Spanish, and then after 2 weeks, we can phone, text, or email to discuss or catch a patient when he or she is coming to clinic. There is written or virtual consent and assent, and then, as I said, waiver of consent. This is a map of the 28 studies that so far have joined, and there may be additional studies, additional centers that join. You can see that we have good representations in the Northeast, Midwest, the South, and then the other, the West Coast. The schedule of measurements is that everybody has demographics, medical history, echo EKG, and clinical labs on day 1. We repeat these and the history all through discharge, and then they're seen at 2 weeks, 6 weeks, and in many instances 6 months after hospital discharge. We then have the annual medical history form at 1 to 5 years. At some point in the study, we don't do whole genome sequencing at each visit. but we request whole genome sequencing at any of these times. That is optional in this study. There are no required lab tests. And every patient's visit will fall within a window. So the 2-week window goes from 1 to 3 weeks. We don't ever want to waste a visit because it's outside a window. Primary outcomes in this study are worst ever LV ejection fraction by 6 months and maximum Z-score by 6 months. Secondary outcomes are a whole variety of coronary outcomes, ventricular function outcomes, valve regurgitation, pericardial effusion, arrhythmias and conduction system disturbances, and then we expect there to be some pretty interesting MRI findings, particularly the tissue characterization. There also are a variety of secondary cardiac outcomes. Basically, every other organ system, we have questionnaires. People can add modules onto those, lab markers of inflammation, whether they get admitted to the ICU, what their maximal vasoactive inotrope score is, how long they're in the hospital, how long their symptoms last, major medical events, and mortality. There is an echo core lab led by Kevin Friedman, an MRI core lab led by Mike Taylor and Andy Powell, and a biorepository that will be at University of Michigan. The time frame of the study, we're in the midst of the planning phase, and we are already through a central IRB. We will be enrolling for the first 2 years, depending on what happens with the pandemic and vaccines. Follow-up visits will be in years 2 and 3 for the cardiac part of it, up to 6 months. Then annual medical history forms up to 5 years. And because MISC is a public health emergency, we are happy to provide phenotypic data to basic and translational scientists and release findings that are urgent to patient welfare really at any time in the study period. I have a lot of people to thank. We have a small working group who reviewed the protocol, the echo, MRI, and biorepository core labs. We have lead study coordinators. At the NIH, we have Gail Pearson and Lynn Mahoney to thank, and our CRO is Health Corps. And a special thanks to Adrian, who's going to speak right after me, Manish Patel and Mary Beth Sun, who is working with Kara for treatment analyses with what we hope is going to be a very fruitful collaboration. Thank you.
Thank you so much, Dr. Neuberger. So to remind you, if you want to use or to do any question, please use the Q&A box. At the end, we will read all the questions for each speaker. So our next presentation is by Dr. Adrienne Randolph. She's also at the Boston Children's Hospital. She's a senior associate of pediatric critical care medicine, as well as professor of anesthesia at Harvard Medical School. And she will present the Overcoming COVID study. So, please, Dr. Randolph, the stage is yours.
Okay. Can you hear me? Okay.
Yes.
I don't have any disclosures. So the Overcoming COVID-19 project has 2 studies. The goal of it is to understand severe disease complications in children and young adults, including acute COVID plus MISC and other complications related to SARS-CoV-2. We have a study of about 2,000 patients, less than age 21. We're doing public health surveillance. And then we have a prospective study with consent with the target of 400 patients for an immunobiology study. We have a website, overcomecovid.org, for more information. We initiated this study in April. We had a lead because we already had a pandemic preparedness network that was ready at 30 sites, and we expanded it. We had been ready since 2013. and we previously did a study in 2009 pandemic. We also had a vaccine effectiveness study going, and then we expanded it. So we had these two studies already started. Our surveillance registry aims are to understand risk factors and outcomes, to better define complications, and to really have this available to inform the government, decision makers, and to answer questions of scientists and help them design better studies. We have one manuscript. We were able, because we had such a lead of being prepared to collect data, that we were able to submit a paper to New England Journal on May 25th on MISC, and then it was published a month later. In that paper, we had the CDC criteria for cases. We published 186 cases we reported on, and we actually captured 213. There was a paper from New York State in the same edition. On MISC, we basically showed the same thing. So we had taken 27 of the cases out that were reported in that paper, with the usual lag of MISC peaking after the positive COVID activity. We had the predominant Hispanic and Black non-Hispanic patients with the average age of 8 years. People have already discussed the effect on the cardiovascular system, but there was a lot of effect on other organ systems, including cases of ARDS. Neurologic complications, we're finishing a paper right now on 200 patients with neurologic involvement and about 30 with severe neurologic complications. These patients were very inflamed. Most of them had 4 or 5 markers elevated. As far as KD, about 40% of our patients, almost 40%, had KD-like features. So basically, the younger ones, they were a bit younger, but not the usual KD age, had 4 to 5 features, and then a little bit older were 2 to 3 features plus labs. And there were coronary artery aneurysms in all groups, though, including those without KD features, and we continue to find that in the groups that don't have KD features, we see the coronary artery aneurysms. Most of these patients got IVIG, and right now we're doing a study with CARA, led by Mary Beth Sohn, to look at all these treatments. I can tell you preliminarily that it's a highly variable what people are doing at different centers for patients, although IVIG is the most common agent still. About half of these patients got vasoactive support, and that's continued, that most of our patients have had vasoactive support. We now have over 400 MISC patients and over 2,000 patients in the data set. Mortality is very low. We have an immunobiology study at 44 sites with multiple questions that we're addressing listed here. We are getting DNA and doing whole exome sequencing. Our suspicion is that a lot of these patients may have primary immune deficiencies, and preliminary data is confirming that. We do get informed consent. We get serial samples, but our study stops about 3 months. And we have a lot of planned assays, additional funding from different groups and agencies for these different assays that we're doing. And we are collaborating with the music study, and they're helping to do the longer term follow-up and the cardiac follow-up. We now also get images. This is all done with waiver of consent, the registry, because it's a public health emergency, but we're getting sequencing data, images, following the patients as best we can. And we have a long research agenda. And we're hoping that this moves into a vaccine effectiveness study. Our immunobiology study is set up to move into a vaccine effectiveness study once a vaccine's available. Thank you.
Thank you, Dr. Randolph. So let's continue. Our next presenter is Dr. Jane Burns. She's the director of the Kawasaki Disease Clinic at Rady Children's Hospital in San Diego, and the